Hi guys, my name's Sanjay Gupta. I'm a consultant cardiologist in New York, and today I wanted to do a video on the subject of ablation. A lot of people who suffer from atrial fibrillation have asked me about ablation. It's a question I get faced with every day, and I thought I'd do a little video just to try and explain ablation to patients and what are the kind of things you should think about before deciding whether to go ahead with it or not. It is true to say that there are lots of people doing ablation, and sometimes some enthusiasts may sort of, try and tell patients that this is the way forward, and people can be left quite confused because there's a lot of conflicting advice out there on Google. So the first thing to say is this video is really about ablation for those patients who have atrial fibrillation, okay? The second thing to say is that it's important to remember that the first thing to say is that ablation is not, there are two types of ablation that patients with atrial fibrillation can have, and I'll talk you through them. But it is true to say that whatever ablation you're having, an ablation is not a natural process. It's an invasive procedure, okay? And therefore, it involves doing something to your body. It involves putting things inside your body. It involves burning around the heart. And that is not natural, and that is not what the heart was geared for. So, it carries with it a degree of risk during the procedure. And secondly, it may have long-term consequences. And because it is a procedure that has not been around very long, it's very difficult to be sure that in the long term there are no long-term consequences of the burning that is done around the heart. So it's always important to bear that in mind. It's not as straightforward as, oh, it's a simple thing, it's harmless. It isn't. It carries with it risk during the procedure, and possibly also long-term consequences, although there is no evidence to say that yet. But it's important to be a little bit skeptical because it's not a natural thing. The body wasn't designed for someone to poke things into the heart and burn bits off. So whenever you're faced with a question like this, particularly one that can carry a degree of risk, and you're contemplating as to whether to have this procedure or not, it's important to try and work out whether what benefit you're going to derive from the procedure, okay? And for me, it's very simple. With any procedure, there's only two things you're hoping to achieve, okay? The first is that you're hoping that the procedure could potentially prolong your life. Secondly, you're hoping that the procedure would in some way improve your quality of life. And they're two separate things. Length of life and quality of life are two completely separate things, and they don't really bear any connection to each other. So, so when you're faced with the question of should I have an ablation, the first question to say is the condition I'm suffering from likely to shorten my lifespan? And if it is, would an ablation prolong my lifespan or, stop my lifespan from being shortened? And with atrial fibrillation, the thing is that it does expose patients to the risk of stroke. And that risk of stroke is generally treated or reduced by anticoagulation, blood thinning medication. It is also important to realize that once you have developed atrial fibrillation, then it doesn't really matter whether you are in atrial fibrillation or not, your risk of stroke remains. That is to say, there are some people who have, for example, atrial fibrillation and you have a shock treatment to the heart, and they come out of atrial fibrillation. But actually, just because they're out of atrial fibrillation does not mean their stroke risk has gone away, okay? So if you're contemplating an ablation because it'll take you out of atrial fibrillation and therefore you think you will no longer be exposed to the risk of stroke, then you would be wrong, okay? Just because you've had an ablation and the atrial fibrillation has been taken away does not mean that your risk of stroke has gotten less. And therefore, you will still require blood thinning medications, even if you have a successful ablation. So you should not really have an ablation because you think it will prolong your life. You should not really have an ablation because you think the atrial fibrillation will shorten your lifespan, and by having an ablation, you're going to prolong life. That is not the reason to have an ablation. Okay? The second thing then to say is, should you have an ablation for quality of life? By quality of life, I mean symptoms. For some people, an ablation, for some people, atrial fibrillation can be very troublesome. Some people get recurrence. So there are people who have paroxysmal atrial fibrillation, where the atrial fibrillation comes and goes, and that can be incredibly troublesome for the patient, because there's this sudden, unexpected change from a regular heart rhythm to atrial fibrillation, and the poor patient is then symptomatic during the atrial fibrillation. The heart is going fast, they feel tired, they feel yucky, they feel dizzy, and they don't know when they're going to come out of it, and that can happen more and more frequently. So for those people, the atrial fibrillation is affecting their quality of life. Similarly, people who have persistent atrial fibrillation, i.e. atrial fibrillation all the time, can also feel tired and generally breathless and yucky. And for them, the atrial fibrillation is affecting their quality of life too. Okay? It is important to bear in mind that there are two ways in which, well, there are actually three ways in which atrial fibrillation affects a person's quality of life. Remember, atrial fibrillation is a disorder both of rhythm, i.e. the heart is beating irregularly, and rate, i.e. the heart can beat very fast. Okay, so both these things, the irregularity as well as the rate, can cause symptoms. So, for example, when you're beating irregularly, the heart is beating less efficiently because you've lost the atrial kick. So you've lost 15 to 20% of the filling of the left ventricle, and therefore there's less blood going around. So just losing that can make people feel tired and generally a bit yucky. However, for some people, it is because, of course, they've lost that kick because they're in atrial fibrillation, but also they're going very fast, or they've lost that control over their heart rate. So they could be sitting and their heart could be going at 100 beats per minute. They could start walking and their heart rate could go to 160 beats per minute. Contrast this with a normal person who's not in atrial fibrillation. Their heart rate will probably be 70 beats per minute when they're sitting, and will go up to 90 beats per minute when they're walking. So the person who has atrial fibrillation where the rate is not adequately controlled will become much more symptomatic, because their heart will be working much harder than it needs to. So if they're walking gently and their heart rate is going up to 160 beats per minute, they will feel like they're doing an activity to make their heart rate go at 160 beats per minute. So when you have symptoms from your atrial fibrillation, the first question to ask yourself is, are my symptoms because of my rate not being adequately controlled, or are they simply because of my rhythm? Okay. And the way you can do that is you can ask your doctor to put you on the treadmill. And when you go on the treadmill, of course, you're irregular, but you will see how quickly the heart rate rises. If you find that the heart rate is going very fast when you're on the treadmill, then it's a rate problem, and the rate needs to be controlled. And that is generally controlled with tablets such as beta blockers, digoxin, calcium antagonists, okay? And in some people, when you put them on the treadmill, you realize that actually the rate is completely normal. It's behaving normally. It's not going too fast. In those people, if they're feeling yucky, then you have to assume that it is just the irregularity. Okay, and a lot of these patients then end up having to have a cardioversion, where they have a shock treatment to the heart to try and get them back into a regular rhythm. So it's very important, if you are getting symptoms from your atrial fibrillation, to try and work out whether it's just the irregularity or whether it's the irregularity and the rate, okay? Because this will help you work out why you're getting the symptoms and how best to treat your symptoms. Now, let's assume it's the rate, okay? If it's the rate, then the best thing is to try and control the rate and stop the heart rate from going very fast when you're exerting yourself. And we do that with the tablets. Now, in some people, despite all the tablets in the world, the heart rate is still going very fast. Okay, so they walk and their heart rate shoots up, and you've given them all the tablets, and despite that, you can't do anything. Those people could be considered for something called AV node ablation. All right. That is one form of ablation, AV node ablation. Basically, what you're doing there is you're saying that, okay, the top chambers are fibrillating, the bottom chambers are listening to the top chambers, and therefore the bottom chambers are going very fast and very irregularly. Now, what you can do is you can break the connection between the top chambers and the bottom chambers, so there's no communication between the two. And now that there's no communication between the two, there is nothing for the bottom chambers to listen to. So you have to put in a pacemaker to keep the bottom chambers going. So you're breaking the connection between the two, but then you're consigning the patient to a pacemaker for life, which will control the bottom chambers. The bottom chambers will therefore beat regularly and will beat at a rate which is decided by the pacemaker. The top chambers will continue to fibrillate, and therefore you still need blood thinning medication. But with this, you don't necessarily need as much in the way of, you don't need heart rate lowering medication, because your bottom chamber is going to be controlled by your pacemaker. I don't recommend it unless there is absolutely no other option and the patient is symptomatic. The patient is really struggling with symptoms of breathlessness or tiredness. Otherwise, I wouldn't recommend it. But if they are, then that would be an option in those people in whom the symptoms are being caused by a rate issue, i.e. the heart rate is not adequately controlled. Remember, again, it is not ideal. This is not what the body was designed for. It was not designed for a pacemaker. It was not designed for someone to break the connection between the top chambers and the bottom chambers. So I don't recommend it lightheartedly. I think it's important that you try everything before you consider that. The important thing also to bear in mind is that in some people, there are those conditions which led to the atrial fibrillation happening in the first place. And unless you try and control those conditions, I wouldn't push them forwards for this, for an AV node ablation. For example, if a person is very overweight, if a person has sleep apnea, those things, I would like to control those first, because if I can control those, maybe that will bring the heart rate down, and therefore maybe the patient will not need this AV node ablation. Okay, so those are the people. So that's one type of ablation. Then there are those patients in whom it's not a rate issue. It is just that they are irregular and they don't like being irregular. If they've lost 15 or 20% efficiency of the heart, and that just makes them feel yuck. All right. In those people, what you can do is you can shock the heart under electrical cardioversion, and that often restores the heart rhythm. But unfortunately, often that doesn't last very long, and most people go back into atrial fibrillation. And sometimes, if that doesn't work, sometimes doctors recommend that the patient goes on something called amiodarone, and then they try and shock the heart again, because the amiodarone can hold the patient in a regular rhythm for longer. But again, amiodarone is quite a toxic drug, so I don't really like using it a lot. And once everything else has failed, you can offer the patient something called an AF ablation. Okay, and the idea behind this is that there is this suggestion that the pulmonary veins, which are the veins that are around the heart and connect the heart and the lungs, they become irritable and they start fibrillating, and those impulses go to the atria and make the atria fibrillate. So in those patients, you can burn the area around the pulmonary vein, and that therefore allows the pulmonary vein to continue fibrillating, but the impulses don't go to the atria, and thereby you don't get the atrial fibrillation. However, it is important to realize that this is an invasive procedure again, and the risks are, and the success rates are very, very variable. You know, they're between 40 to 70%, okay? 40 to 70%. And a lot of people require more than one procedure. And a lot of people actually, after they have had this procedure, then start complaining of things like ectopic beats. They become very conscious of their heartbeat, etc. So it does have a place, but only if you have terrible symptoms, which are not because your rate is going very fast, because of no other reason. Again, I would say that unless you treat what has caused your atrial fibrillation in the first place, there is no merit in having an ablation, because if you continue doing those things that led to the atrial fibrillation in the first place, then even after the ablation, you'll go into atrial fibrillation again. So those things are things like, you know, if your diet is bad, if you're very overweight, if you have sleep apnea, those are really important things to try and tackle first, because if you can tackle those, in general, your quality of life will improve anyway. If you're overweight and you lose weight, your quality of life will improve anyway. And remember, the only reason to have an ablation is simply because your quality of life is made unbearable by the presence of atrial fibrillation. The atrial fibrillation is a byproduct of inflammation within the body. If you treat the inflammation, then that is the better thing. The ablation sorts out the atrial fibrillation. A, it will not take away your stroke risk. B, if those things that led to the atrial fibrillation continue in the background, then the atrial fibrillation will simply come back. So in essence, what I'm trying to say is an ablation does have a role, but only if you have very bad symptoms which are unbearable and affecting your quality of life in a bad way. Now, quality of life means different things to different people. You know, if you like running and you can't do it because you have atrial fibrillation, sure, that's important. On the other hand, if you're a sedentary person and you know you're breathless all the time, that's another reason. So what I'm not saying is that I'm saying that each person has their own subjective notion of what their quality of life should be, and it really depends on you, the individual, to decide whether your symptoms are bad enough to warrant this. Having said that, please don't take it lightly. It is an invasive procedure. It does carry with it some risk, and it is not a natural, it's not a natural treatment by any chance. And of course, whatever you do, the most important thing is treat your lifestyle, treat those things that led to this happening in the first place, because undoubtedly you'll feel better. And in some cases, it may make your quality of life so much better just by losing the weight or treating the sleep apnea that the atrial fibrillation doesn't bother you anymore. Another thing I wanted to say is that atrial fibrillation begets atrial fibrillation. So the more atrial fibrillation you have, the more you will have. The more you've had, the more difficult it's going to be to get you out of it. And that is why ablations are more successful in patients who have paroxysmal atrial fibrillation, i.e. the atrial fibrillation is coming and going, than patients who have long established atrial fibrillation. So if you're a young person who gets paroxysms, you're likely to do better, provided you treat everything else like the weight and diet and exercise and mindset and all that. Provided you do that, you will do better from an AF ablation than someone who has established AF. All right. So I hope this was helpful. That you keep giving me. Thank you so much. I'd be really grateful if you'd consider sharing these videos. And if you need to talk to me, this is me. Okay. And this is my website. And this is my Facebook page. And this is my secretary, Jeanette's number. So thank you very much. And if you enjoyed this, please consider sharing it. Thank you so much. Bye.